Welcome and good morning, everyone, and welcome to the happiest Wednesday of the year so far. It is time to discuss the CY 2027 final rule, contract year 2027 final rule. And gosh, if it isn't just like the signal of the start of another long Medicare season, right? The We were just announced the AHIP date last week. Probably saw an email from us yesterday morning about that. We know AHIP exam will come out on June 22nd, which means product releases aren't too far behind that, which means AEP isn't too far behind that, which means we all need to know what the heck is going to be going on this AEP. We have not yet had the pleasure of meeting. My name is Randy Lober, Growth Marketing Manager here at Action Benefits, one of the largest field marketing organizations in the Great Lakes region. Happy to welcome you all along here today because this is one of the most fun parts of my job where I get to spend some time with you all talking about how to grow your books of business. And in this case, we're talking about how to do so compliantly over the next year. Well, actually, technically, beginning on October 1st of this year and on through next year as well. So without any further ado, let's go ahead and get started talking about this final rule and what I think you're probably going to love inside here. I would probably describe, and if you've been in the industry for any length of time, you'd probably describe Medicare regulation as sort of a pendulum or one of those silly rides at the carnival or maybe on a boardwalk where you're going back and forth, back and forth. And over the past few years, I would argue to you, dear audience attendee, that that pendulum has swung toward consumer protection through friction, right? CMS has created more friction in the enrollment process, right? We've reinstated the 48-hour rule for scopes of appointment. We have made it so there's a bit of a delay between educational and marketing events held in the same venue. We've really done a lot of things to kind of make sure that beneficiaries have a cooling down period each and every step in the process before they begin their actual enrollment with you helping them out. But I would also suggest to you that as a result of this rule, and there's nothing else you take away from this session, it's that the pendulum is swinging back the other way with the CY 2027 final rule that will be swinging back toward consumer access through efficiency. I want to pause here for a moment. I see Carol is having trouble hearing things. Is that true for anyone else in the crowd? Can you give me a quick yes or no so I can check in before we go forward? Okay. Well, all right. You all are there. So, Carolyn, go ahead and maybe rejoin the session if you need to, or otherwise, thank you all for letting me know that you're all well. Or Carolyn, send me another message and I'll see if we can work with you in the next little bit here. So if the pendulum has swung back and forth for a while, we've been at the high part of that friction part of the pendulum for a while, and I want to get a sense from the crowd of what that friction might have cost you. So you've actually some of you have found the raise hand feature near the bottom of your screen. I'm going to give you some practice using that. This is not just of me talking for a 45-minute session. This is I'm asking for some audience engagement here too. The more you put in, the more fun you get out of it. So I'd like you to raise your hand, first of all, if you've lost a prospect to the 48-hour rule, either because they've confused or they've gone somewhere else after that 48 hours. Have we run into that at all? And again, use that raise hand feature at the bottom. I'm seeing lots of hands come up. Over half of you so far. I'll give you another minute or so to weigh in with that. But a good deal of you, at least half of you, if I'm doing some back of the napkin math, have lost a hand to that. I'm going to lower your hands and then ask you something else. Have you been skunked after a Medicare education presentation? You've been out there, delivered your best Medicare 101. You've been out there, you've developed rapport, relationship, and then your beneficiaries, the people across the table from you, just fall off the face of the earth because you can't talk to them right away. You can't have the deployment right away. Has that happened to any of you after a session? Again, use that raise hand feature, and not quite half just yet, but I'm seeing about a quarter, up to a third now. Uh, you again use that raise hand feature. What else does that friction cost you? Lay leveling in at about a third there. And one more ask of you. As part of your TPMO disclaimer, where you read, we do not represent all plans in your area. We represent X plans from Y carriers. Um, and please call SHIP or 1-800-Medicare for all your options. Has anyone got confused about you referring them to SHIP or gone off to SHIP for help, thinking they could get something different and been misinformed or misguided? Have you heard of your beneficiaries running into that or your prospects running into that? And you are raising your hands much faster than you did for the last one, right? Depending on the state you're working in, we know a lot about SHIP. We know SHIP is a nice free resource to be sure for people to access, but we also know that those folks don't have the same education requirements you do. They don't have the same, professional obligations you do to help folks out. And frankly, their livelihood does not depend on being a reliable source of truth for a Medicare beneficiary in all cases. So the help they can get is inconsistent at best. And so often, as when we hear when beneficiaries call into SHIP that they're being misinformed, they're not getting what they needed out of that call, and they end up in a plan that doesn't really fit their needs. Maybe a doctor or a drug or something else isn't working out for them, and gosh, that's a bad place to be. We hear Mary Lee chiming in with the idea that CMS in general has been her nightmare, not SHIP. And that's a fair characterization here as well. We'll dive into some things CMS might be doing to change that. In any case, that friction has cost some of you to various degrees some relationship with the people across the table from you, right? It's cost you a chance to enroll someone when they might have been ready to. It's cost you a chance to help someone when they might have needed it, or it might have caused confusion, right? Because they went off to SHIP or someone else to guide them through the process and didn't get the guidance that you are very capable of providing. So let's take some good news. There are some things changing here in contract year 2027. But before you get really excited, I need you to pump the brakes and read the third line on the screen. Every change I'm about to describe rather goes into effect on October 1st of 2026 in that pre-AEP window when you can start talking plan information with your beneficiaries. So we can all be really excited about everything I'm about to say, and you should be really excited about everything I'm about to say because it's going to make your lives easier, I think, I hope, I know. And none of it applies until October 1st. First thing to think about is that 12-hour buffer between events is eliminated. So and we'll kind of give you to give you a sense of how we'll lay out the discussion here today. I'll give you a little bit of a history, show you some of that pendulum swing from friction to speed, right? I'll tell you what's happening in contract year 2027 and give you some examples of what's possible here from going forward. So, beginning with the January 2021 rule, you could stack marketing and educational events in the same place. You could have them close to the same time to each other, and that was all well and good. And then April 2023, the pendulum swings back the other way. And CMS says that's actually resulted, in our estimation, in a lot of high pressure enrollments, a lot of agents, a lot of beneficiaries feeling like they can't leave, like if they were stuck there for the educational portion, they're stuck there for the marketing portion, and we've got to give them some way to exit, right? To gracefully exit. And as you're weighing in here, I see that some of you are already replying to this as a joke, and it cost you some clients, and that's absolutely right. That April 2023 rule did prohibit marketing events after educational events within 12 hours of the same venue. So if you're going to have an event at 6 o'clock in the morning, couldn't have your next event at that same venue until 6 o'clock p.m. And nobody's coming to either event, whether it's 6 a.m. or 6 p.m. So the rule, CMS has heard you. CMS has heard your complaints, and whether or not your complaints, at least carrier complaints or other agents that have written in, and they've eliminated that 12-hour buffer. But instead, the standard changes a little bit, right? Still has to be a clear signal and a clear opportunity for that beneficiary to leave. There's got to be a clear signal that the education portion is ending and that we're moving on to the marketing portion of the session. And there must be a clear, defined opportunity to leave the session as well. CMS outlines in the rule that that could be as simple as a snack break or a restroom break or a formal leave now if you like. But either way, there's got to be some sort of implicit and explicit opportunity for the beneficiary to leave, which means, in very plain language, if you have a Medicare 101 at your local library scheduled to run from 10 o'clock to 10:50, you can now start your marketing event at that local library at 11 o'clock, where you can start talking a bit about plan details, maybe presenting someone from plan details from one of your preferred carriers in the area that your clients may be interested in. So that's a pretty significant change. So suppose then, dear reader, and again, we're asking for participation today. This isn't just the Randy Show. Suppose you have 40 people, you marketed your tail off, you got 40 people in your Medicare 101, that ends at 10:50, and your marketing meeting does start at 11 o'clock, where you'll be talking about specific plan details from your local Blue Cross Blue Shield plan or what UHC or Humana offers in your area. What do you say and do to stay compliant? I'd like to see some of your brainstorming here in the chat before I share some answers with you. So we see a few options coming in publicly and coming in privately. Remember, when you're chatting, you have the option to choose whether everyone can see your chat or whether just I can see it. Mary Lee says publicly that at 11 a.m. I'll begin a specific marketing and sales event. Can't get any more clear than that, right? And some other variations coming in privately saying you have a 10-minute break between sessions. At 10 minutes, or at 11 o'clock rather, I'll start talking about plan details. As long as you're clear, you're explicit, that's okay. But you must have that pause. You must pause for that compliant snack or restroom break. And I do say compliant there, connected to snack, right? You still have your $15 limits in place. None of that changed here at all, but be mindful of that going forward. Clearly signal the transition on screen. So if you do have one presentation set up for your educational event and another presentation queued up for your marketing event, make sure you have a clear break slide in there. I'll tell you why in just a moment. And again, as Mary Lee pointed out and a few others pointed out privately, you want to clearly announce that transition from educational to marketing. Now I bring this up, and I'll bring this up a few times later. Throughout the final rule, CMS does acknowledge that agents and brokers are getting a lot more flexibility, right, in returning to some of these previous interpretations of the rule. They also mentioned at various times throughout the rule that the best way to enforce some of those things, well, it's going to be via two ways, right? It's going to be via what they hear from beneficiaries, via complaints, via 100 Medicare or otherwise, and it's going to be done via secret shopping. Now, CMS also emphasized in the rule that it's the carrier's obligation chiefly to make sure that their first-party entities, their downlines, their sellers, you are compliant with the rules. So you can expect secret shopping from both carriers and from CMS at these events. And I would expect that in October, when the gloves come off and you're able to do these, that odds are better than zero, right, that you'd find a secret shopper at these events. So you want to make sure that you're doing everything here with intention, that you do have that pause built in, you're clearly signaling and announcing that transition, and your snacks all fall within the $15 limit. So no steak dinners at your Medicare 101s. Second thing that you'll be able to do is scope of appointments, again, beginning October 1st, can now be collected at educational events. So in January 21, CMS had previously allowed this to happen. In April 2023, that rule prohibited it. So again, the pendulum swung from freedom to friction back to freedom a little bit here in 2027. So now at those Medicare 101 events, you can collect a scope of appointment. Meaning that if you have a relatively private and secure place in the room, you can now have a one-on-one appointment or enrollment before the prospect leaves the room. You can either put it on the books or, because of what we're about to talk about here in just a minute, you can now have the appointment right there in the room if you have, if you've arranged your space strategically enough. And that's a pretty big deal, all things considered. So the third thing I'd like you to know is that the 48-hour rule will be eliminated effective October 1st of this year. But remember that 48-hour rule required a 48-hour delay from when the scope of appointment was signed and when the actual appointment, whether it was a consultation or enrollment, could take place. So we see again the history here, the pendulum swinging back and forth. We saw the 48-hour rule first appear in that September 2011 final rule. If you've been in the market that long, removed about a decade later, exactly a decade later, in January 2021, but came back again in the April 2023 rule, again after CMS, through their own surveillance efforts and through responding to beneficiary complaints, saw some high pressure things, right? Where seniors might have been pressured into enrollments that they might not have been appropriate for them. In contract year 2027, though, CMS has changed its tune and has removed the 48-hour rule, again, effective October 1st of this year. So still have to follow it through that. But the 48-hour rule will be removed, which means you can now take the scope and then get right into the conversation that the beneficiary came there to have, whether they walk in, whether they call in, or at any time, right, they're ready to have that conversation. Which means that you will now be able to conduct an enrollment immediately after you get that valid signed SOA. So taking those first three changes together, that means you could, in theory, enroll someone right after your Medicare 101 or right after the marketing event that follows your Medicare 101, which really streamlines, beneficiaries' access to you, streamlines your relationship building with them, and really stops them from having to leave the house 3 separate times to get the information they're coming to you for. So quick check for pulse check here in the room. After an educational event, suppose a prospect walks up to you and says, "Hey, yeah, can I just sign up today?" What's your next sentence? What do you say? See a lot of positive reaction to the rule here in the chat, publicly and privately here as well, saving time, saying some yes. I would mostly agree with your yeses. I would qualify the yes with one sentence. Yes, if you qualify, right? If I have a scope of appointment from you, right? And if you are actually qualified to enroll in Medicare or a plan here, right? You have Part A and B, you live in the planned service area, so on and so forth. So it is a big yes, but maybe a yes and or a yes if you qualify here in this case is just to be exceptionally safe. But the big rule, as you're pointing out here, is you can complete the scope of events. You don't have to have that 48-hour waiting period, and which means you can conduct those appointments right away. So again, if you have a secluded area of the room set up, maybe some dividers where you can do the appointments right there on site, while people who are waiting, that's an option for you, right? Depending on how you manage your space. It could be, hey, let's set up a phone call for tomorrow, right? Because I don't have to wait 48 hours. Or let's have a call, when I get back to the office here today and I have everything in front of me I need to do this enrollment with you. Whatever it is, whatever your solution is, whatever best fits your workflow, the answer is yes, they can just sign up today, assuming they meet all the qualifications for the plan they want to enroll in. And some good options there as well in the chat here. Fourth thing you'll see is that the TPMO disclaimer is changing within that you'll start. Now, it's not going away, to be clear, but it is changing. So that third-party marketing organization disclaimer, the one that says we do not represent all plans in your area, that first came out in the May 2022 final rule, and gosh, you guys were not happy about it then, and you're still not happy about it now, and I hear you on that. In 2023, the rule got a little harder to comply with, right? Because it was revised, and now you had to say the number of carriers you represent and the number of plans you represented in that beneficiaries area, in that beneficiaries county. There's confusion about how you put that on a website. There's confusion about how you put that anywhere else. There's confusion about how that shows up in emails. None of that confusion has gone away, to be clear. Still need to have those two ingredients in your disclaimer. But what will change is when you have to read the disclaimer. So right now, the current state is it has to be read within the first 60 seconds of the call. So you can't even say, "Hi, Miss Smith, how you doing?" You have to immediately get into, or fairly immediately get into, "I don't represent every plan in your area. Call SHIP if you need help," which isn't a great look for business. It's not a great way to start a relationship, not a great way to start a conversation. CMS has heard those complaints as well and has changed the timing of when that disclaimer must be read, again, effective on October 1st of this year. So instead of being read within the first minute, the disclaimer need only be read before you discuss a specific plan's benefits. That means you can get through, "Hi, Miss Smith, how are you?" You can get through qualifying your prospect, figuring out whether or not they have Part A and B and whether their Part B is actually active. You can get into figuring out their service area. You can talk a little bit about their health history and their drugs and their doctors they prefer covered. And you can do all of that before you talk about a specific plan's benefits. But you have to read your disclaimer before you get into talking any specific benefits. The other thing is that the SHIP statement will be removed from the disclaimer language again, beginning on October 1st of this year, which means you no longer have to awkwardly refer clients off to somewhere else in the middle of your call for help. CMS frankly saw a lot of confusion due to that part of their rule. They recognize the sort of inequality between SHIP organizations. Some state SHIP organizations do really well to advise consumers. They're well funded and provide top-notch advice. Other states kind of don't. Because it's a state level program, everything's kind of patchworky. There's 50 different degrees of quality that health beneficiaries got from them. And so to remove some of that confusion and to instead allow consumers to rely on you without introducing this third party into the mix, that portion of the disclaimer will be removed. So what's now possible is you can have a conversation that sounds like a human. You don't have to sound like a customer service representative at any other big box organization you call into, letting you, with the compliance stuff right away. You can be a person first. And that's probably the important part of being, working in this field, right, is being a person that helps people. You also no longer will have to direct clients and prospects to SHIP counselors, though you will still have to call out the 1-800-Medicare for all your options as part of the disclaimer. The other thing you'll be able to do is use defensible superlatives, things like best, most, goodest, best, bestest, all those sorts of things that now can have a place in your conversations, again, beginning on October 1st of this year. Again, a little history of that pendulum. In January 21, CMS, their final rule, formally barred misleading statements. So we couldn't just make up statistics and say, this is the best plan of the nation, right? They said, put some guardrails on that. In 2023, they require that every superlative statement you said or a carrier said, particularly in their marketing materials, had to be substantiated by some sort of data. In 2027, we're allowed to return to things like most and highest quality and things like that, so long as the stat is defensible, meaning you can cite it in one sentence. So you could say, "Miss Smith, this is the highest rated plan in Oakland County." Be totally okay there. You could say, "Miss Smith, this has one of the highest comprehensive dental maximums in available in your county, and I know that's a benefit that's important to you." And that's okay there because it's both defensible, right? I can look at all of the plan information around me and say, yeah, that's true. And it's not misleading, right? I'm not trying to steer into a plan. I'm just saying, "Miss Smith, these are the facts of this plan. It does have a rich benefit that you might want to take advantage of." Should point out this does not change the guidelines on the word free, right? So you still cannot use this is a free benefit or this is a no cost benefit. You're still talking about $0 premiums, $0 copays. Nothing is free under this rule. So you can now say things like, this plan does have the largest PCP network in the state, if it's true, or this plan does have the most hospitals in network, again, if that statement is true. And I suspect actually that with a lot of with this particular guardrail coming off, you're going to see more carriers lean into their strength of networks and which hospitals they don't and do have in their networks and kind of do a lot of math behind the scenes, which they're already doing anyway, but they're not putting it in front of us. But I imagine we're going to see a lot of carriers put this in their marketing tools, which means you'll have more defensible numbers to put in your conversations as well. On the left side of your screen, and got a few phrases that are not yet compliant. Want to hear your thoughts about how we can make them compliant. So just put a few thoughts in the chat. Take one, take two, take three. What do you think you can do? Uh, the best plan in the state, still under this final rule, even though it's a superlative, would not be defensible under this rule. So I want to think about how you might change that statement and rephrase that. Includes the most comprehensive dental in the county. Is there a way we can make that, we can change that language to make it compliant under the rule, or provides the most meal deliveries in your state? Are there some ways we might need to change that? Love to see some of your thoughts in the chat while I take a sip of water because I've been talking here for a moment. This is the only five-star plan in the state, the highest rated plan in the state. Absolutely, all things you can say. A quality and highly rated insurance plan in the state, absolutely something you can say. You could say things like it's the highest rated plan in the state based on the CY 2026 star ratings if you want to get real technical, right? But also, even though you don't have to include that last portion here about based on CY 2026 star ratings, gosh, is that a nice thing to include though when you're citing that statistic because it gives some credibility to your claim. Your client, your prospect knows that you've done your homework in doing these sorts of things. So being able to add that little clause to that sentence, gives you that much more credibility within the enrollment call. Second one includes one of the highest annual dental maximums in your county. We Most comprehensive is hard to define. It's hard to defend. But if I say it does have a high annual dental max, well, that's easy. I can put all the dental maxes in the county right next to each other and say, yep, that's the one. Or these two have the same. If this is making this one of the highest dental, right? So just small shifts in the language there. The last one CMS was kind of nitpicky about is the most meal deliveries in your state. Now, most plans do provide 24 meals post-discharge, but they were kind of picky about the language, and we're specific in this example, and this is why I called it out, is for those who qualify. Because not everyone qualifies for those meal deliveries, right? You don't just get 24 meal deliveries willy-nilly. You have to have an inpatient hospital stay or be discharged, and then you're eligible for that benefit. So for those who qualify is key when you're talking about not only meal deliveries, but things like SSBCI benefits, anything that the plans cover as a result of, those supplemental benefits that are covered under, for those with chronic conditions or anything that's triggered there, like extra OTC or healthy food allowances, those sorts of things. Those who qualify is going to be a key addendum to any statement that talks about those. Yeah, so provides numerous meals for those who meet qualifications. Absolutely. A good rule, though, to go forward with is if you can't cite it within a sentence, don't say it. So if I can't back it up, if I don't have a statistical body or a firm statistic to add in, probably best left on the sidelines until I have something that can help record that. Or not record that, backstop that. The record appeared on the screen here, and I had a brain slip there. Next thing you'll love, especially if you've been doing this on your own, is that call recording retention requirements are slimmed. So again, with that May 22 final rule that introduced the TPMO disclaimer that we do not represent every plan in your area, there also came along a call recording requirement. And many of us broadly interpreted that rule in 2022 to say, I got to record every call and hold it for 10 years. And yeah, that was the case then, right? In 2024, CMS modified that rule to only include sales, marketing, enrollment calls. So if you knew a call was just to schedule an appointment, or if you knew a call was just about service, like Miss Smith needed to order her fifth ID card of the year, you didn't have to record those. But anything that was in the enrollment chain, right, the sales, marketing, enrollment calls did have to be recorded and does still have to be recorded and maintained for 10 years. In 2027, this changes a bit for you. Instead of a 10-year retention policy, CMS has okayed a 6-year retention policy, again, beginning with any call on October 1st of this year or later. For the first 3 years that you retain that recording, it must be in audio format. This includes both phone calls, webinars like this one, or video calls. Anything that can be recorded essentially must be recorded here in this case, unless it's a face-to-face meeting. And those first 3 years of the recording must have audio. Again, CMS likes that as an enforcement mechanism and an audit mechanism to go back and hear how the words were said. Whether it is you might like this plan or you're gonna like this plan, right? There's a difference in how you say those words. Um, and they want to be able to monitor and take enforcement actions that way. In years 4, 5, and 6, you may then switch to complete transcriptions of those calls, which so complete written or typed transcriptions of those calls. CMS was unclear about the method for how they might do that in the rule, but it did seem to leave open the doorway that AI transcriptions of those calls would be acceptable. But honestly, still waiting for a little bit of guidance on that or some more clarification from CMS on how that will look. So if you asked me how Action was going to approach that right here, here and now, I don't have a great answer for you yet because we're a little unsure just yet based on the rule of how those transcriptions must be built. Should remind you, though, that enrollment records, including telephonic enrollments, must still be held for 10 years. So if it's a call connected to the enrollment, that audio still got to be held for 10 years. But if it was a marketing call, right? So not the enrollment itself, but you were talking about a plan and then they needed some time to think about it. The conversation about that plan's got to be retained for 6 years. The actual enrollment call needs to be retained for the full 10. What's now possible, though, is that FMOs like Action Benefits, agents, and brokers who are investing in their own call recording sessions or systems now can spend some of their money on things other than storage, right? Especially once that year 4, 5, and 6 is straightened out and we know exactly what's acceptable in CMS's eyes for generating those transcripts. That frees up 3 years of audio storage, right? 3 years that you don't have to pay for a cloud system. 3 years you don't have to pay for extra storage within your AMS or to work with that as well. So it does free up a lot of budget, a lot of resources, industry wide, all things considered. So those are those marketing changes that we hooked you in with here today. 6 changes that we think you're going to like. In the back half of the session here, we also want to talk a little bit about how star rating, supplemental benefits, and for those of you who are employee benefits minded, creditable coverage will be changing as well. First thing is that star ratings measures are getting trimmed. Before I show you any text here, just a quick note in what is changing here for you on the slides. Yeah, I'll still give you a little history. I'll tell you what's happening in 2027, but rather than a what's now possible section, you're getting a highlight section here on the right, some examples of what's in, what's out, what it all means here. So since the inception, essentially, of the Medicare Advantage program, CMS has adopted a wide range of ratings measures to look at both plan quality and care quality delivered by those plans, as well as customer satisfaction by those plans. And over time, the number of measures that go into those star ratings has ballooned to some frankly high numbers. Plans do get rated on all of those measures, and they get dinged on all those measures as well. And one ding on the wrong measure can hurt pretty big. We need to look no farther than the lawsuits just last year, right? Where one of the big lime green carriers filed a suit against CMS because their overall star ratings for one of their contracts was dinged down to a 3.5. Because they did not have a translator available on one call out of all the thousands of calls they took. But CMS sampled that call, said the translator wasn't available, docked their star ratings a whole half point, which made them ineligible for star rating bonus payments. And as you can imagine, they were pretty mad about that, took CMS to court and won that suit and actually got the star ratings and the bonus point payments back. So, in thinking about all of that, and with a little bit of egg on their face, frankly, CMS has said between now and 2029, they're going to phase out star rating measures that don't directly reflect patient care. So, it's while it's important to have interpreters available, um, it really doesn't always have a direct outcome on patient care. So they are removing many measures related to things like appeals. How quickly did the plan get to appeals? Was there a defined process in place? They're going to look at things like care management, like whether or not the beneficiary was enrolled in care management appropriately, or whether the care management staff of the carrier appropriately followed up with the beneficiary as well. Again, after this suit with the big line green carrier, they are looking at removing interpreter availability and TTY availability for call centers. And curiously, they're removing customer service, so call center customer service as a star measure rating as well. I will offer no comment other on that, other than just to say that is a choice. The other thing CMS is doing is they're declining to implement the previously finalized Health Equity Index. Essentially, what that program would have done was give an extra bonus to carriers who delivered 4+ star ratings plans in disadvantaged areas, or so areas where it's difficult to really deliver high quality care. So if you had a 4-star rating plan or a 4+ plan in Detroit, for example, or even in rural areas, for example, where for either socioeconomic reasons or network reasons or all kinds of reasons, would have been eligible for an additional bonus payment. That will no longer be implemented here. The other thing that's new is hemp-derived products would now be covered under special supplemental benefits for the chronically ill, or SSBCI, which you've heard me say a few times throughout the session. History here is that cannabis has long been considered a Schedule One drug and long been therefore illegal here at the federal level, at least in the United States. But over time, the definition of cannabis has been refined, and hemp-derived products are no longer legally considered cannabis. And within that context, CMS has ruled that hemp-derived products may be covered under SSBCI. These are things like oils or supplements or things like that that could be administered again under that SSBCI benefit. Though CMS was very clear to point out that there are limits on the THC content that's allowable in those contexts. So it's really focused on like pain management, right? Not just like catching a buzz, wherever the case might be. But remember, though, that SSBCI isn't open to anyone and everyone on a Medicare Advantage plan, right? There are some very specific hurdles you have to clear to be eligible to receive those benefits. Beneficiary can't just have a chronic condition that's listed. It's got to be complex and probably has some comorbidities as well. It must be something that puts the beneficiary at high risk, and it must be something that requires care coordination, and a doctor would have to be able to attest to all of that. So, beneficiary, to be clear, can't just I have asthma, right, and then be clear to take hemp products under SSBCI. They'd have to have, doctor certification that they have a chronic condition that impairs their quality of life, and that they would be eligible for SSBCI. And only then could they use an OTC card, for example, to purchase hemp-derived products here that have, admittedly, a smaller THC content. Speaking of OTC cards, those do see a rework here coming up. In the past, carriers have had flexibility to send paper checks or even offer cash reimbursements for OTC benefits, but for the most part, that's largely gone the way of the dodo. So now CMS has decreed that OTC benefits must be loaded onto prepaid debit cards, and funds cannot roll over year to year, though they can roll over quarter to quarter, as you've seen in many plans throughout the areas that you work in. Ultimately, this is no significant change for most beneficiaries because nobody probably was getting a paper check from their carrier for their OTC benefits, although stranger things have probably happened. 10th thing to think about is that the mid-year notification of unused benefits is no longer required. So in April 2024, CMS says, gosh, all these supplemental benefits, silver sneakers, gym memberships, dental vision hearing, all those other things that are built in that are not part of the core medical plan, are they being used? Do beneficiaries know about them? Do they matter? Do they make a difference in plan selection? And to help encourage the use of those benefits, CMS would have required plans to issue a mid-year letter in the month of June to all beneficiaries who hadn't yet used a supplemental benefit and said, hey, you haven't used your gym membership yet. Do you want to go do that? You still have it available to you. Here's how you do that. That requirement was suspended by the new administration in September of 2025, and as of this year is now officially repealed. So carriers will no longer be issuing that mid-year notice. Again, because the program was never fully implemented, there's no significant change for your beneficiaries here, but just know that it's not coming down the pipe if you were expecting it. Now, I guess I should say that doesn't mean, oh, things are changing here. That doesn't mean, of course, that you can't do that same mid-year notification, right? It's an excellent opportunity for you to check in June, July. Hey, Miss Smith, are you taking advantage of all the benefits involved in your plan? Do you know how to use that gym membership? Do you know how to access your post-discharge meals? Can I set you up with that companion care? Do you still have the number in hand, right? Good opportunity for relationship building, good opportunity for service touch to keep that client sticky going forward. That said, I gave away part of my check for understanding. Maybe already been thinking about it here. But suppose a client has seen reporting on this rule and he wants to see if his prescription drug plan will cover marijuana, medical, of course. What do you say? What's your response here? Can I get medical marijuana covered under a PDP? Not covered, not on a PDP. No, 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 lots of no's. And the answer right now is no. Remember that SSBCI benefit is administered under the Medicare Advantage program. They're not part of Part D. So if you did want to get a hemp-derived product, you'd have to have that Medicare Advantage product there. We talk about the THC limit there as well. We should note that as this rule is currently written, that medical marijuana cannot be covered either as part of any formulary, Medicare Advantage formulary or a Part D, standalone Part D formulary here as well. However, in the time since this rule has come out, the administration has rescheduled marijuana from a class 1 to a class 3 drug, puts it in the same class as other controlled substances and painkillers and things like that, which means it does give the green light or could give the green light for medical marijuana to appear on formularies later on down the road. Whether Medicare will adopt it, we don't know. Could it appear in the employer group commercial markets? We don't know yet, but it's now possible for it to be covered here. And it's now possible for it to appear on formularies. Again, that decision was made after this rule came out, so the rule is silent on it. But if I were an interested observer, that's one thing I'd want to keep my eyes on going forward. Speaking of employer-based plans, if you are employee benefit minded or you deal with a lot of people that are aging out of their employer-based plans, here's a spot to pay a lot of attention to. Account-based health plans no longer subject to creditable coverage notice requirements. Meaning since like the beginning of the Part D program, employers have long been required to notify employees of whether or not their drug coverage is creditable, at least as good as what a Medicare PDP would offer them. And we also know that if the employer fails to notify their employees here, that employer faces a civil penalty there, and the employee can face a lifetime Part D late enrollment penalty if they don't enroll when they're supposed to, because maybe they're Medicare eligible but do not have creditable drug coverage. A wrinkle CMS is throwing in here, and probably the one thing that it gives you a little bit of pause in this rule out of the 9 positive things that we've shared so far, is that if the plan is CDH driven, consumer driven health planning, so if the plan is wrapped in a health reimbursement arrangement, an FSA or an HSA, those plans will no longer be obligated to provide notice to the employees about whether or not their coverage is creditable. I'll say that again. If you've got an HRA, FSA, or HSA, no longer required to provide uh, creditable coverage notice. And if I know anything about big business, if they're not required to do something, it gets really hard for them to do it, right? Um, we should also mention, though, that because of the Part D redesign, plans must cover 73% of their average drug cost to be creditable, right? That used to be a 60% threshold, but with the Part D redesign, drug coverage has gotten a little more expansive here. So it's actually more likely that in the coming years, you'll see employer plans that are less creditable, and that creates a big risk point for your potential Medicare enrollees. Now, it does, of course, reduce the paperwork burden on employers. They don't have to get out that creditable coverage for employees enrolled in those plans. And we should note that because of the Part D redesign, drug coverage, whether we've seen it in the PDP market, we've seen it in the Medicare Advantage market. Drug coverage is costing more, and because employer plans will be held to that same sort of standard here officially in 2027, their drug costs will go up here as well. So how do you solve for that? Consumers should seek the notice from their primary traditional health plan. So if you have an FSA wrapped around a Blue Cross plan, for example, or an HSA wrapped around your Blue Cross plan, or HRA for that matter, wrapped around your Blue Cross plan. Each year, Blue Cross, for example, does put out a report on which of their plans meet the standards for creditable coverage and which ones don't. So you would have to go actively seek out that report in that case. And for if you do have the fortune of having a relationship with this Action Benefits, we do get those in your hands as soon as we have them. Other carriers like UHC, for example, does include that creditable coverage notice right inside their renewal package for group coverage. So that's an option for you as well. Yeah, Glenn, you're exactly right. Any non-CDH employer plan will still have to report it. The justification and the difference CMS noted in the rule here is that when a plan is wrapped in an HRA, FSA, or HSA, it's actually not technically a health insurance plan. It's a funding mechanism for the health insurance plan. And CMS came down on the side of saying that just the funding mechanism itself has no obligation to report. But we still want to look at what the primary underlying health plan looks like and figure out whether that is creditable. What this means, again, is that there's going to be a gap, right? Because especially as HSAs have seen, a huge uptick lately, there's going to be a gap in what your employees and prospects are getting from their employers. That's going to be a problem for you to solve. Whether that's asking the employee to get in touch with their HR department because they should have that creditable coverage notification, or asking the employee to go back to the broker that brokered their employer plan. There's going to be some hurdles to clear there. Yeah. And Glenn, I hear you, but don't shoot the messenger. I'm just the messenger in this one. One thing that I was pretty excited about that did not make it in the rule, CMS had floated the idea of allowing an SEP, like if your PCP left the network or if a key specialist left the network, CMS toyed with the idea of allowing an SEP in that case, right? Like, hey, your doctor left, we want to ensure continuity of care. Go find a plan that has that carrier or has that provider or network. They chose not to implement that rule this time around, but left the door open for future implementation. To be clear, But what I should remind you of, especially with some ongoing strife in the Michigan market here, SEPs may be granted on a case-by-case basis if there's a substantial disruption to a network, like a whole hospital season up and system up and leaves the network. You can appeal the CMS for an SEP in that case. Um, your carrier reps, and certainly we can help you do so there as well. But again, those SEPs are granted on a case by case basis, something you got to ask CMS for, not something that's freely given to you. And again, we can help you walk through that process when you need to. So, ladies and gentlemen, you've seen it all here. You've seen all those big changes we have to talk about. I'm going to wrap it up in a nice little bow for you here in just a minute. But after everything you've heard so far, what's on your mind? What seems to be the biggest impacts on your business here so far? What do you like? What do you not like? I'd love to see what you're thinking here in the chat. Freedom, 48-hour rule going away, having events back to back, 48-hour rule, 48-hour rule, 48-hour rule, events. So clearly you guys are appreciating that aspect of the rule. But again, I must remind you that does not go that the change does not go into effect until October 1st. So please don't start having appointments all willy-nilly everywhere just now. So as we head into the home stretch, a few things for you. Again, I would argue that the pendulum has swung back the other way, where CMS is now promoting consumer access through efficiency. They're getting rid of some of that friction. So the question for you is, are you getting on the ride, or are you waiting in line? Are you getting on the pendulum, or are you waiting to see what happens? Let's think about what actually changes for you practically here in the next few moments. So first of all, your event workflow is going to shift, right? And honestly, given that you now know how important events can be in your event workflow, it's worth scouting out venues now, booking them up for October for that pre-AEP or pre-AEP period. Because we know there's going to be probably some competition for your local libraries, your local senior centers, just as there always is. But I would wager that competition is going to get even stiffer. So when you can, do file and report your events. And again, your team here at Action Benefits can help you report those to CMS and carriers here as well. And you're always going to want to start with the educational event. Rarely is the case where you'd start with just that marketing event, unless you had a pretty good setup with that carrier already to do so. So you're going to build your authority, build your trust in that educational event, and then pause for a moment, right? During that pause, you can again invite scopes of appointment from those who are interested. And if all you're doing that day is a Medicare 101, then maybe you can skip to the last step on the screen here and have enrollments if someone is ready in that case. If not, after that pause and after that clearly defined break, you can give your plan-specific education, again invite your scopes, and then conduct those enrollments on site if you so choose, again, beginning on October 1st of this year. The other thing that shifts is your in-appointment workflow, right? And this is a guideline we provide to our downlines here as well. If you're not yet partnered with us, I'm happy to talk with you around that here as well. But that disclaimer, that TPMO disclaimer, had to be given within the first minute. So we'd say, "Hi, Miss Smith," and then we do not represent every plan in your area, right? And immediately confuse the beneficiary. It no longer has to be right there in the appointment. Still got to start the recording early, right? But you can now delay that TPMO disclaimer to just before you start talking about specific plans. So CMS was clear in the rule to point out that just talking about the fact that plans have dental, vision, and hearing benefits, for example, is not enough to trigger the disclaimer. But when you start talking about a specific plan or start talking dollar figures, that's your signal that you need the disclaimer here. So that's the last possible point you could claim it. You could read it there. Some agents probably are still going to keep it there at the beginning out of habit, right? Better to cover your bases at the beginning in some schools of thought. You can also put it in anywhere here, but that is the last possible spot you could put it before you start talking about plan details. That said, you do have some newfound freedom, but as we've talked about the pendulum here, be wary that the pendulum can swing both ways. So there's a few areas I can see here, and probably a few areas you can see here, where it's easy to get burned. If you blur that line between your educational and marketing events, there's not that clear pause, and a secret shopper or a beneficiary complaint comes in, not good looks for you. A lot of those over time, not a good look for the industry. We can see ourselves back in being re-regulated fairly quickly, right? Pressure on those SOAs too, right? We still can't mandate a sign-in sheet, right? And we still can't say you need to sign this SOA before you leave or anything like that. But I can see there's opportunity, right, for some unscrupulous folks to take advantage of the situation and pressure enrollees to um, sign that SOA on the spot and then create a high pressure enrollment. So kind of a combination of those 2 points. If you're creating pressure within that scenario, that's a spot where you can get burned. And if your superlatives aren't documented where you're, saying where you're throwing around best all willy-nilly, right, and you don't have, star ratings or stuff to back it up, that's an easy spot to get burned here too. And remember again, kind of what triggers enforcement and what triggers the rules to be rewritten. It's beneficiary complaints. CMS is always, transparent about having the beneficiary's interest in mind, and they are kind of reactive, right, in responding to what beneficiaries are saying about what the agent and broker community is doing. Be on the lookout for secret shoppers. Means we've got to do everything right, the right way the first time. Every time here, secret shoppers, I would suspect we'll see out in more force. We'll see more call recurring audits, and we'll also see CMS does put a burden in the rule on carriers for monitoring and reporting you all uh, for compliance, and we can expect to see some carrier support there as well. So my final thought here is that speed is back, but still pressure is prohibited. You don't have permission to lean into the stereotype, right? And what I mean by that is if you sat in an ethics training, um, like really common statistic they like to throw out in the ethics trainings is that the general public thinks of us as health insurance agents somewhere between lawyers and used car salesmen in terms of our overall trustworthiness, right? We don't want to be those people. The only way to break that stereotype is by being good stewards of the community, being partners, being good advisors to people across from us, not high pressure salesmen. And that's what I would encourage you to keep in mind here going forward. So, your action plan for right now, if you needed 6 steps to kind of take away from the session, is revise your TPO disclaimer in scripts, digital, and print formats, and get approval for new materials where required. Redesign your appointment flows or scripts to reflect where that new TPMO disclaimer is going to go. So especially if you work in an office with multiple producers or if you have people downline, your own downlines, right? Think about how you're working with them about where that TPMO disclaimer will go. You'll have a decision to make, and I see a few questions here in the chat. I'll get to them in just a moment here. Decide on what your 6-year audio transcript and retention strategy will be, keeping in mind that phone enrollments will still require you to hang on to them for 10 years. If you are using Action Benefits call recording solution, you know that we've still got you taken care of here, so there's not many decisions to be made here on your part there. But if you're using your own solution, either be in contact with your vendors or figure out what's happening in-house on that side there. If you are not the only producer in your agency or the only person working in your agency, make sure that everyone knows about your updated event and scope of appointment requirements here as well. Know that there's a bit more freedom, but with more freedom comes a bit more responsibility. And I would encourage you to book your events early. As fast as venues filled up before, I suspect they'll fill up even faster this year because of the opportunity, the great opportunity that Medicare 101s and non-marketing events can produce together. And again, I've said it once, I've said it 1,000 times. Remember that any change we've discussed here does not go into effect until October 1st. That said, I promised you an hour. We're here for an hour. Thank you all for your time and attention. I will get to that question here in a moment. But should you need to go rather, I do invite you to stay connected with us. You can find us on LinkedIn at the Action Benefits Company. If you'd like to get a hold of me, you can find me at learning@actionbenefits.com, or you can talk to anyone in our office at our main line, 248-356-8585. We'd be happy to help you out and answer any questions you might have. I want to thank you all for your time and attention. I'm going to take a moment to read what's going on here in the chat here as well. So Terry specifically calls out the commercial men talking about the dollar maximums on their. Thank you all for those, and you're welcome to those of you saying thank you. Uh, sorry, brief squirrel moment there. But Terry calls out that plans that are saying you might be eligible for $1,200 in groceries without talking about Medicare Advantage plans and really talking about SSBCI, right? Because you need to be eligible for SSBCI to access that grocery benefit now. CMS has effectively said in the rule they're aware of those things, that they don't like them, that they're non-compliant, but has also, kind of out of the other side of their mouths mentioned that they don't always have enforcement resources to deal with them. So the best way to deal with those is when you see them, be the squeaky wheel, right? Make a complaint to 1-800-Medicare. Um, and if you happen to be in a position, if you are also a Medicare beneficiary, even better, right? You can be the squeakiest of squeaky wheels and saying, that doesn't seem quite right to me, and formally report that. If you can tell them what channel you saw it on and what program, what time of day, CMS can look back at whatever marketing organization ran that and work on enforcement actions through there. Again, it's gonna take an army to defeat that. Welcome, you're all inducted into the Army. If you see something, say something. But please do call and report those when you see them. Thank you all for the kind words here today. Thank you all also for doing business here with Action. Couldn't be more happy to work with such a great group of people here as well. I'm going to pause here, take a sip of water, stick around for any other questions you might have. But if you must be off for the morning, then good luck, and we look forward to seeing you all again soon. By the way, we do have our June and July training calendars pretty well stocked. They should be on your screen here now when you click out of here. Feel free to see what's coming up next and what is sounds good to you. That said, taking a sip of water, feel free to put in any questions you have as we wrap up our time here together. All right, ladies and gentlemen, this is not a speak now. Oh. Do I have an in-house service department for clients as an FMO? Excellent question, Mary Lee. So, on our Medicare and individual side of the business, we do have on both sides of the business, we do have an in-house service department. We have a 9-person service department. Any agent that works with us does get a dedicated account manager. So they're like your person that you talk to when you have a problem that needs solving. But they're also backed up by the rest of the people on that team. So you're able to call in or email in and get support on anything from app processing. We can do that for you. If there's a claim issue you need investigating, payment things you need investigating, our team is happy to work on that with you. We've been doing that since we've been in the Medicare market, and indeed since we've been in the group market since 1987 or so. Not to make that sound so sales pitchy, but we've been doing that for a while. Services where we kind of think we stand apart from a lot of other regional FMOs in the area. And we'd love to help you out any way we can. What about members calling in? Mary Lee, if I'm understanding you right, being your service department. So generally the way that works is we uh, don't want the beneficiary to know we exist. Um, it's bluntly speaking, because then what they end up doing is they call us. They call us. They call us. They leave you out of the relationship, and that can be a kind of a cause a deterioration between you and that person. So instead, what we'd ask you to do in those situations, or we ask all our agents to do, is to let our team know what's going on via an email or a phone call. We can take it from you from there, but we actually ask you, generally speaking, to serve as the middleman, saying, "Hey, I've got someone working on this for you," or the middle woman. In your case, I've got someone on this working for you. And our team's very good at providing follow-ups. If there's some, I want to see if there's actually someone still on the call who's can talk to you a bit about that. No, oh no, the last account manager left a few moments ago. But generally speaking, we prefer you to stay member facing, but we do take care of everything behind the scenes for you if there is a service need. You're very welcome. And again, Mary Lee, feel free to give us a call or give me an email, right? If you want to talk more about what's next and where we can help out, happy to start that conversation with you as we go forward. All that said, we're a few minutes over time. If you are still hanging around, you're either enjoying the conversation or you left a while ago. In either case, you're going to hear me stop the webinar here in just a few moments. I look forward to seeing you all again soon at another session. And good luck and good selling out there.